Hi, everybody. I'm Julie Block, President and CEO of the National Eczema Association, welcoming you back to Eczema Awareness Month. Today, we are providing you the results of our third in a series of 4 surveys we're conducting this month. This week's survey is on advocacy and access, and I'm delighted to have with me today Dr. Adam Friedman. Dr. Friedman is the professor of dermatology at George Washington School of Medicine and Health Sciences. Dr. Friedman has long been a champion for the National Eczema Association and serves on our scientific advisory committee. And he is also notably the chair of the DermaCare Access Network, which is a very important coalition advocating for better care for all dermatology patients. So welcome, Dr. Friedman, and thank you for joining us today.
Thank you so much, and thank you for everything you do, Julie. Phenomenal work.
Thank you. We appreciate that. We got a long ways to go, and getting the input from our community and learning what is actually going on in their lives is an important part of our process to advocate appropriately. So with that, I'll get right into one of the data points that we learn from our community as it relates to their access to care, access to medications. And what we learned first was that 30% of the respondents to our survey have experienced what is called step therapy. First, can you tell us what step therapy is and your experience with it in your practice?
Sure. Yeah, I'm actually surprised that number is only 30%. I would have expected it to be higher. But step therapy, or what's also known as fail first, is pretty much that idea that a patient has to fail or try another medication than the one their physician wanted them to receive based on that prescription. And they have to try it for different amounts of time, and there could be many different reasons why that medicine isn't sufficient, but they need to go through the rigmarole of that first. And certainly hearing about that and applying that to any other area of life, that sounds absurd, that taking another medicine which the person who knows best wants you to use, but try something else first before you have to get there. And this is an extremely disabling element of our healthcare system that is not only a huge impediment for the patient, but it really strains the doctor-patient relationship because there's a lot of misinformation or lack of information about this process, and often the patients are told that the physician's the one who's responsible and that we're the ones who are holding this up, and that's absolutely not true. We're fighting the same fight.
That's right. That's right. Thank you for that. Yes, it's an experience that we work on the state level with coalitions to get state legislation around these things, but your point is exactly right. When the patient and the physician agree on a medication and an insurance company or payer comes in and says, no, you got to fail this first or try this first, and there may be risks to those medications. We have a steep hill to climb to get this out of our experiences.
I think what's really missing is significant transparency, because this isn't told to patients. When we prescribe a medicine, we often don't know how much it costs, or even sometimes insurance will cover it. What we've been doing in our practice is we've actually been giving handouts to patients detailing this process, the prior authorization process, where we have to appeal to insurances saying why we want this patient to be on this medication. And this process can easily take a good 14, even 21 days while the patient waits. And I think just knowing that this is happening can ease some of the stress associated with not getting one's medication. Because if you don't know what's going on, our minds always go to a very dark place. We assume the worst, but there could be a lot going on behind the scenes, but there's just not transparency about this.
That's right. That's right. In education. Well, that brings me to another data point. We learned that 48% of the respondents to the survey didn't know that they can appeal their insurer's decision. And that is more prevalent than we'd like to think. That is usually what happens first, and people can get very.
I hear this all the time. Yeah, this is This is very common, and the common story is this. I see a patient, I prescribe something, I don't hear anything for months. And the patient comes back, and they're not better. And they're not better because they didn't get their medication. And their answer is, well, I was told that it's not covered, and that's it. And they just didn't try for anything else. And it's not their fault. They don't know. There's not this, well, we hope there are certain resources out there. I think, National Eczema Association is for one, but a lot of people don't even know about those resources. So they assume it's either all or none. If insurance says, nope, sorry, we can't give this to you, game over, and that's not the case. And we as the physicians, not just the physician, but the medical assistants, the whole team can really help fight back and argue why someone needs that medication. So communication is of the utmost importance, getting us involved early on to help push back to appeal these decisions. And often we can actually make a difference. We really can overturn these decisions.
That's right. And I can't let this conversation go without remarking and letting our community appreciate and understand this is a significant burden on your physician's offices to deal with what they call prior authorization, to appeal decisions. So you need to work with your provider to ensure that they're going to go to bat for you, because that's what's necessary. It's a team. You both have to work together to get the medication that you need and deserve. And
Absolutely.
Unfortunately, quite a process most of the time, but you can't give up. The last data point that I wanted to bring up, Dr. Friedman, was 55% of respondents who had non-medical switching had less than a month's notice about the change in the medication coverage. So we got to first talk about what is non-medical switching and how do we advocate and what do we do if this happens to your patient?
So the idea behind non-medical switching is that the insurers decide for one reason or another, they're not going to cover certain medications. They're not part of the formulary or their formulary. That's the terminology for the medications that they will cover at different tiers. Now, certainly there are different reasons for this, and I think every payer has the right to make these decisions. The problem is when they make this decision and give you very little time to figure out what the next best step is, or even informing you and the physician. And there are actually certain states where they can do this, and the pharmacist will just change the medicine without even telling the physician. And so you're cutting out a big piece of the pie, because when we talk about the care of anybody, it's a large family of people. It's the patient, it's their network, it's the physician, it's their extenders and their support, and it is also the pharmacist, and it is also the insurers. But when you start pulling people out of that kind of network, things go wrong, and it's extremely unfair to patients because they're notified about this. They don't understand. They don't know one medicine for another in most cases, and so once again, it comes down to transparency and clear communication, and that's really the major failure here.
Right. Well, it's an astounding number, 55%. And again,
I believe it. Yeah.
To those listening, NIA advocates on a state-by-state level on this particular issue to introduce and pass legislation that mitigates and makes this transparent and gives the patients and the providers a chance to get appropriate medication, enough time to get it, and make that difference in people's lives. In some situations, not necessarily for our community, but it can be a matter of life and death. In some.
I mean, I've seen examples, and patients will bring in these letters where, let's say you prescribe just simple things, topical steroids, which there are many different potencies and strengths, where you'll prescribe one, and the non-medical switching is to another steroid, but of a class that is several orders higher. And this could be a steroid for the face or the groin, and now some non-physician is saying, oh, no, this one's okay, when there actually could be some dangers associated with that. So that's terrifying to me, because if the patient had not told me about this, they could have gotten this other steroid and caused significant harm to themselves without knowing.
That's right. Well, thank you so much, Dr. Friedman, for joining us today. To our community, look for our next survey, which is for our caregivers in our community, to learn more about how eczema impacts your children and your families. That will be out next week. And again, thank you to all of our eczema warriors that are out there unhiding eczema. Hashtag unhide eczema, follow it. Extraordinary things are happening in our community for our community in raising awareness about eczema. So again, thank you so much.
Thanks for having me.